Go ahead.
I'm start sharing the broadcasting now.
22,
Okay.
Welcome back, and thank you for being patient as we got through some technical difficulties. Thank you, Dr. Poli. And at this moment, I'd like to introduce Dr. Eduardo Locatelli, the Medical Director of the Phil Smith Science Neuroscience Institute ALS Center of Excellence.
Good afternoon. Thank you, and thank you for your patience. A little stress under these circumstances so challenging with technical difficulties. But let me quickly go into this presentation, catch up on time. The topic is empowerment through clinical research, and give you some updates. I have no disclosures to give. I want to give you the vision of the ALS Center at Holy Cross Health, and is to provide the best local care in ALS. Phil Smith, the person that sort of initiated and helped us to bring the clinic, went around the country, had trouble having care at the end of his condition. So he gave us a large donation and says, we want you to provide local care. And that's the vision we started with. And second, he told us there's no treatment, so I want you to find treatment, and I want you to do it the best possible with technology. So we decided to have this concept of merging the clinical research with the disease management. And we decided to use technology and also multidisciplinary care, because this is a team effort. It cannot be done by one single physician or care provider. And also it cannot be done if you don't pay attention to do it in partnership with the patients and caregivers. So this was the mission we set up to do. The first thing was to design the clinic. And we have a design in which we have 6 rooms and a center and a conference room to meet the team. Then the team members will go around the rooms, seeing the patients which do not move. And we also then, particularly with the COVID time, and as we just recently heard from telemedicine, we set up a strong telemedicine infrastructure to be able to reach the patients. The second was to write a program called CareSense that is allowing us to track disease progression and evaluate all the alternative off-label treatments, efficacy. And then we display in a friendly format that I'll show you in the next slide. And third was to jump in and participate in interesting and hopeful experimental clinical trials to see if those interventions will change the disease progression. Here's the display. This is something that we enter in a proactive way. Every patient now participates in research. We offer this. They sign consent to participate, so everybody is into the registry. And we use many scales here. I'll show you 2, the famous ALSFRS. And we track them over time. You can see these patients since 2018, even to now. We can follow the disease progression point by point. In the vertical lines, you can see when the patient starts using Radicava, when the patient starts having non-invasive ventilation, when he started alternative treatment, when required power wheelchair. Here on the vital capacities, you can see when the patient started alternative treatment. So we can see if these alternative treatments are changing these curves and trying to see if that gives us an idea whether these treatments, which are off-label, as mentioned, do or not have an impact. With this, we have be able to see that the Radicava approved treatment seems not to have a significant impact when you look at it globally. And as published, it's most likely a treatment that has more impact in those that are rapidly progressing. Regarding other treatments, we have seen in some alternative treatment did not have a significant impact, and therefore we stopped recommending them using this technique. So for those things that are not going to have double-blind randomized trials, we can track and trend this and discuss with these visual displays with the patients whether those treatments are or not being effective individually. We have right now a couple ongoing trials. We just finished 2. This one is one, and they are physician-initiating trials. The one is the impact on Ludexta, which is an approved treatment for this excessive laughing and crying called pseudobulbar affect. We are looking at from different perspectives. Dr. Table Gray, Lauren Table Gray, and Emily Plowman from the University of Florida in collaboration are looking at this medication to see if it improves the speech and swallowing in patients with ALS. So looking at the same medication from a different angle. We are towards the end of recruitment. We'll have data towards the end of the year, at the beginning of next. The second is the collaboration we have with the sport medicine team. We have many patients as the arms get weak, the shoulders get frozen, and they're painful. We have seen the injections are significantly decreasing pain and allowing physical therapy to be way more effective. So we're trying to see what are the predictors that the injections will work. So we're in collaboration with the sport medicine team, Dr. Manalak. And then with the main topic of today is the HIL ALS Platform Trial. John Healy was a patient passed early this year that worked with the Mass General team and gave a very generous donation and allowed that team to sit and gather very smart researchers, clinicians, statisticians around the world, and trying to improve in the design of the trial. This includes now 54 sites in the country, but all of them have one central RIB to make sure that this quickly gets implemented. If you look at this area of Florida, there's 5 centers in Florida that are participating on recruitment for this trial. And here in the second part is the University of Florida, the University of South Florida, the University of Miami, and the Mayo Clinic in Florida, as well as Phil Smith here in Fort Lauderdale with us. These sites, we already started enrolling in July 30. This year, we have 5 people that are being screened and consented. The other sites, I know they're soon to start enrolling, and they will allow all across Florida to have access to this very exciting platform. Now, what is the goal of this trial? Is they're trying to accelerate drug discovery in ALS. This enables to use multiple therapies, just not one single agent. In the traditional way of research, you can have 10 therapies will take over 2,400 patients and 1,200 placebos, and about 12 years to complete. In this new platform with multiple treatments at the same time and sharing placebos, you decrease the number of participants and decrease the number of placebo, saving a lot of dollars, but also reducing the time from 12 years to about 4 years. So this will allow us to get to effective treatments much quicker, and that is very exciting. What are the benefits? Well, as I said, you share placebo, so it's 3-to-1 ratio, and we start multiple treatments. There's 5 already treatments being selected. And the selection of these 5 were over 30 international applications. So there was a vetting process through 30 drugs on the pipeline. And they were looked, they were interesting, they were in the different stages, and a selective of neurologists that specialize in ALS selected these 5 treatments. 3 of them already are part of this trial that is enrolling. 1 actually even before next year. It seems that about November, a 4th drug is going to be added to the regimen. The design is been done with participation of patients too, and this is something they require. The patients want to have trials that were shorter than the typical 1 to 2 years. This is 24 weeks on placebo, and if you complete that and you were in the placebo arm, you will go into the open label, so you will receive medication. So there's a very good benefit about it. And also is that the time to achieve effective treatment is much quicker, and is, like I said, 12 to 4 years. So it's over 50% faster than the typical trial. So here's a little bit of the design. Initially, the patients will be enrolled in the main trial. Here's the first stage. And after you pass that, means we're going to draw blood and do an electrocardiogram. And if your heart's strong, your kidneys are good, and liver and bloodhounds all healthy enough to participate, then you will go into the second phase. You will be randomized to therapy A, B, or C. And in a minute, I will talk about those individual agents. And then you randomize 3-to-1, and you see 3 will go in active drug and 1 will go in placebo in each of the arms. And then you see at the bottom, all these placebos will be shared, and therefore the distribution of placebos will be strong to compare to the other therapies because we share placebos on the 3 arms. So therefore the randomization 3-to-1. Also, if you finish, like I said, if you were in the placebo, you will receive medications if that's what you choose to. But if not, you can have a 30 days washout period, and you can be back into the big arrow and re-enroll in one of the other arms. So allowing you to continue to participate within the same trial very quickly from one agent to another is that's the best choice for or option for you. And here are the agents. One of them